So I'm going to ask everybody in a minute to introduce themselves. Mel and Richard are providing the interpreting for the meeting today, and they will swap between themselves as they need to. And also, just to let you know, the meeting's being recorded, if everybody is okay with that, because that makes the note writing much easier. So I hope everyone is all right with that. And again, in case people have arrived, since Tatum said it before, at some point in this first meeting, if everybody's okay with it, we're going to take a group photo of the meeting to show how many people have been involved in it all. And the first part of the meeting is going to focus on people's experiences, and the second part of the meeting is going to focus on people's on what the agencies are planning on doing, and then we'll have a final quick discussion about what we're going to do next. Okay, so first of all, can we just go round and introduce ourselves? Now, just to say one thing, my internet connection is a bit unstable, so I might disappear once or twice. I thought I was about to go then. So if I will come back. But Tatum, if you can, I disappear. You can keep it going. Okay,
I will. No
much.
problem at all.
Can we? I can't see everybody on the screen at the moment because Mel is spotlighted. So
okay.
Could you just put me back into gallery so that we can just do the introductions?
You could actually do it on gallery yourself.
Myself.
Yes, okay. On the top right corner, there's a view button.
Oh,
if
yeah.
you put it on gallery view, in fact, everybody can do that if they don't want to see the spotlight. You know, then everybody, you know, you can see who's in the meeting then.
Okay, right. So I can see everybody now, I think. So I'll introduce myself first of all. For those of you who haven't met me before, I'm chairing this meeting and I'm one of the board directors on Healthwatch. Tatum, if you could introduce yourself next, please.
Okay, good morning, everyone. It's Tatum here from Healthwatch Leeds, and I support Jonathan to chair this meeting. Good to see you all.
Okay, thanks. So I'm just going to go through and call people as per who I can see on the screen. So the next one is Alison Spear.
Hi, I'm Alison Spear, and I'm involved in the meeting to feedback on recent experiences.
Okay, thank you, Alison. Now it's Hannah from Healthwatch.
Morning all, my name's Hannah. I'm Chief Exec at Healthwatch, and I've been part of this group since we started just about a year ago, actually. So hi, everybody.
Rosie.
Hi, I'm Rosie Halsman from Leeds Teaching Hospitals Trust. I'm lead nurse for patient experience, and along with Christina, we are looking at accessible information standards for the trust.
Thank you. Carl.
Hi, my name is Carl Proud, and I am a project officer for Leeds Hearing and Sight Loss Service.
Okay, thanks, Carl. Stuart.
Morning, everyone. I'm Stuart Morrison, team leader at Healthwatch Leeds.
Okay. Now the next person, I'm not quite sure who you are because
I think it's me because I don't think I've put my name on when I signed in yet. So I'm Jane McDonnell. I'm a Healthwatch volunteer, and I'm doing a master's degree in advanced integrated health.
Okay, thanks. Welcome, Jane. Howard.
I'm Howard Beck, and I work for Adult Social Care and Health. I can't see your hands, Howard. Yeah, a little bit, that's a little bit better. Sorry, I couldn't see his hands quite clearly. Okay, yeah, that's better. So again, my name's Howard Beck, and I work for Adults and Health.
Okay, thanks, Howard. Helen Butters.
Hi, I'm Helen Butters and I work in communications and engagement at Leeds Clinical Commissioning Group.
Okay, thank you. And Caris Green.
Hi, good morning everyone. I'm Caris Green. I'm the Chief Officer at Leeds Society for Deaf and Blind People.
Okay, thanks, welcome. Next one is Sharon Moore.
Hello everybody, I'm Sharon Moore. I'm the Equality and Diversity Manager at the NHS Leeds Clinical Commissioning Group. And like Hannah and Tatum, I've been involved in the Inclusion for All Hub since it was developed and established a year ago.
Thanks. Heather?
Good morning, everyone. I'm Heather Thrippleton from Leeds Community Healthcare Trust. My role is Patient Experience and Engagement Lead. And apologies in advance, I'm going to have to leave just before 11:30. But nice to see everyone.
Okay, thanks, Heather. And I think you're going to put some stuff on chat if we don't get to you. Right.
I think Howard's, sorry. Howard's just saying that he has to leave at 11 o'clock as well.
Okay, okay. Jason?
Oh, there you are. Sorry, I couldn't find him. My name's Jason Vesey. And oh, there you are. Thank you. I couldn't see properly. So my name's, and I'm, yeah, my apologies. I couldn't see Jason. I'm Director of Supporting People and Agencies in Yorkshire, and I'm based in Leeds. And I work with many different people and agencies within the community. So that my job is to visit and support them.
Okay, thank you. Julie, next.
Hi, my name's Julie Roylefer. I'm the Clinical Team Manager for the Health Facilitation Team at Leeds and York Partnership Foundation Trust, and I'm the Team Manager for the Assessment and Referral Team within that same trust as well.
Okay, thank you. Anna from Healthwatch.
Morning everyone, yeah, Anna from Healthwatch here, and I'll be writing the notes for this meeting today.
Thank you, Anna. Lisa.
Hi, I'm Lisa. I'm the Learning Disability Lead for Leeds Community Healthcare, new in post and first time at one of these meetings. And apologies for my camera, it's my mum's laptop.
Always blame your mum. Okay, Lisa, welcome. Thanks very much for coming. I hope you understand what's going on. If you get any queries, then please ask. Christina.
Morning, everybody. My name's Christina Kozłowska. I'm the Head of Patient Experience at Leeds Teaching Hospitals, and I'm on the call with Rosie. Rosie and I together support a lot of the work that the Trust does to enable us to move further towards reaching the requirements of the Accessible Information Standard. It's really nice to be here as always.
Okay, thank you, Christina. Dahlia.
Hello everyone, I'm Dahlia. I'm a project manager in the City Digital team, and I'm here because we have some engagement opportunities that I wanted to share.
Okay, thank you, welcome. And the last person I think is S. Smith. Sorry, I haven't got your first name in front of me.
Hello everyone, I am a law student at the University of Leeds. My name is Shayla Smith and I'm a Healthwatch Leeds volunteer.
Okay, thank you, Shayla. Thanks for coming along. Right, okay, well, we all know each other very well now, which is good. And so I'm just gonna.
Sorry, Jonathan, I think it was Richard. Oh, is Richard Jackson the other interpreter? Sorry.
Yes.
Okay,
yes.
sorry. Yeah.
Yeah, you'll be seeing Richard in a minute. Okay, so just quickly run through the ground rules for the meeting, for doing a video conference meeting. If everybody, I think virtually everybody's got their name on the on their iPad, on their screen, which is really good because that really helps with knowing who's speaking. When you do speak, if you can just say who you are as well, in case somebody else can't see you at that particular time. When you're not speaking, can you make sure you're muted, please, so that we don't get any extra background noise? And if you've got problems with accessing, then you might find that if you turn off your video, then that will improve the bandwidth and you'll be able to hear what's going on. But please turn your camera on when you're speaking. And as we did before, we'll spotlight the interpreters when we need to. And deaf people, if you're wanting to focus on the interpreter, you can do that by using the pin function on the top right-hand corner of the interpreter's screen. We might have to do a bit of repetition if people drop out or their vision or sound goes a bit wonky, so be prepared for that. And one of the things I've got to say is make sure you haven't got a bright light behind you, but I can see everybody's faces, so everybody seems to have done that extremely well. So that's really good. Okay, so let us now move on with the meeting. But before we do that, as we've now got lots of people here before some people rush away, Tatum, if everybody's okay with this, we'd just like to do a photo of everybody who's at the meeting, as this is the last one that's focusing on accessible information standards for the next 6 months. So if everybody would like to smile and look beautiful, then I'm not sure whether Tatum or Anna will take a photo of us.
I will take a photo. It's just that if anyone don't want to be in the photo, you can actually turn off your camera now, because then we will want to promote this on social media, website, and so on, just to capture, the words of around AIS, promote it to the city. So if anyone don't want to be in the photo, I will give you 1 minute to switch off your camera, if that's okay with everybody. Okay, so I'm just going to take a screenshot if nobody object. Okay. And then I'm just make sure that comes out. Yeah, it comes out very beautifully. And so I'm going to do just make sure to do one on the phone as well, just to make sure. Okay. That's lovely. Thank you, everybody. Thank you so much. It's looking really nice.
Okay. Good, good. I hope everybody got really well dressed up for that this morning. Okay, so now let's move on to the next item, which is, Tatum, if you can run through the actions that have been completed from the last meeting.
Certainly.
Can we just swap over between me and Mel, please?
Okay, so let me do that first of all. So I swap you. So you're wanting to be spotlight, right, Richard? Yeah.
Yes, thanks.
So again, that if people wanting to see the gallery view, you could just do it yourself.
I think Alison's having a problem seeing the interpreter.
Okay. So Alison, Richard has been spotlighted, so should be appear on a big screen. Can you see him?
I think the problem is that Richard is in portrait and not landscape. Turn yourself down, Richard.
So Richard, if you can turn your phone to landscape, probably that will help. I don't know. Yes. Oh, that's much better.
Thank you.
Thank you. Can Alison see you okay now? Yes?
Yeah, yes, thank you. Yep.
Okay, great. So from the last meeting, we had 3 actions really from the last meeting. So one is about capturing each organization, health and care organization's top achievements around AIS work. So that has been done. So thank you everyone for submitting your achievements and your plans for the one things that you're working on to myself, and Dex and I, we put it together and into a piece of promotion material. We're just wanting Carl to double check whether the materials can be read properly with a screen reader, and then we can promote it far and wide to the city. So, and then once that is ready, and then everybody, you can promote it to your own organization and to your network too yourself.
Tatum, I'm just wondering, how are you also planning to put that into BSL too?
So we can do if with the help from organizations, yes. So BSL, we're wanting to do it in audio too for blind people. So that's just to capture people's work over the last year, from when the Inclusion for All Hub first launched up to now, really. So that should be widely promoted. Yeah. Okay. And then secondly was trying to look at some COVID specific barriers to people with disabilities when accessing health and care services. So for that one, we're going to discuss in details in a minute. So I'm not going to talk too much about that one, but all the information that we have gathered so far, plus what the organization told us, it has been sort of a summarized to prompt the discussion in the next agenda item. The third action was about preparing a survey, because there's so much good work is going on, but we wanted to make sure that has been translated to the ground, that people's experience has been improved. So for that, we're wanting to capture people's experience in the next 6 months in order to reflect the progress made. So again, that will be discussed in a bit more details later on in the meeting. So so that's just my quick update from all the actions has been completed from the last meeting. Does anybody have any questions? So if not, then we can move on to the next item.
Okay. Thank you. So we'll move on to item 3 now, where we're going to focus on people's experiences. So can I just check? I'm not on the agenda. I've got what barriers we already know about people with visual impairment, and I've got there a couple of things listed: the appointment letter, etc. Has everybody got that, or has only me got that?
So you and I have got that, because I thought that we just open up the discussion with what we have already known. So if you can probably just read it out to people, that'd be great. Thank you, Jonathan.
Okay. Fine. So, so we'll focus on experience of people with a visual impairment, first of all. We already know a couple of examples, problems with appointment letters being sent out in an inaccessible format, so people can't read them. And then we've heard about difficulties going face-to-face appointments alone, not knowing what the layout is of the system, and particularly things have been changed with COVID, with one-way systems and socially distanced labels and that kind of things. So that's a couple of things we've picked up so far. But what would be useful would be to hear from people with visual impairment and the organisations about your experience in relation to that first, and then we'll move on to the next area. So anybody want to add to that list in terms of the challenges for blind and visually impaired people?
Yeah, please. There's a lot around barriers around visual impairment at the moment, especially with the COVID. For me, I used to have text messages instead of, now I'm just getting an influx of hospital letters. I've got a broken leg at home, and I'm actually got no support as well, because my other family are in support bubbles and I live quite rural. So I've actually had to go in and speak to my GP, and he's actually had to now put me as clinically vulnerable, which means I'm stuck at home for the remainder, which is quite difficult. And when you get in just a box of food a week on the doorstep, and you don't actually know what you're getting, and it does take a lot of your independence away. And my GP at the moment specifically, the classing phone calls as they put them down as an appointment. So if that's quite confusing, if you're going to go up thinking you've got a face-to-face appointment and then say, oh no, it's a phone call because it's a 2-mile walk to my GP. There's a lot of things that people don't really consider, and my GP stopped sending out messages as well by text, and are sending emails which are conflicted and confusing.
Okay, so there's some really key things there in terms of communication and the way in which that's changed, which certainly, I mean, in real time, we can pick those kinds of things up. I'm looking at Hannah now and feed those back, can't we? But what would be the solutions to those, Jane, from your perspective? How can the situation be improved immediately for you?
For me, it needs to be clearly digital. Everything needs to be digital or audio. So when I receive an appointment, they need to either ring me so I can hear through my hearing aids, or that I need to get a text message so I can create an event on my phone and save it, because then it organises myself. I mean, at the moment, because now I'm registered clinically vulnerable, and it's very difficult for me to access the hospital, even to go back and get my POT seen to, because I'm supposed to have surgery on my leg and I have no support whatsoever. And I think there's better ways around just appointments in general. And I mean, if you attend an appointment now, you can't be guided in an appointment situation because you've got to keep a distance. So that means that it's down to me to find a seat and manage getting round an actual clinic, which is pretty much a nightmare. So, and there's been occasions where you may walk into people, sit on people's laps, just thinking that you have a chair, and it being an embarrassing situation.
Okay, thanks so much. Christina, I'm wondering whether if you've got any thoughts about that from your perspective at the trust.
I mean, clearly, it's really sad to hear what you have to say, Jane. And the experience you describe, you know, is not one that we would want any of our patients to have. So I'm speaking from a hospital perspective. I can't account for any of the experiences that you've had from a GP perspective, which is a separate thing entirely. We are challenged. We know we are challenged within the hospital in terms of getting communication right for our patients right now when they have identified needs. And as I've spoken before about at this meeting, part of that problem right now relates to the lack of ability in our hospital systems to be able to accurately capture consistently the needs of people, so that as they move from department to department, the information is shared with different clinical teams so that they can act upon it. So in your situation, what you're describing in terms of it would be preferable to receive all your communication in a certain format. We don't have at this moment in time a good mechanism in the hospital that works to be able to share that sufficiently, which is why we have escalated and prioritised a piece of work to improve our hospital system to enable that to happen. And that is planned for the beginning of next year. So we're trying to improve the functionality of our digital stuff so that I'm not a digital person myself, Jane, but so that it can do that for you and for everybody else that needs it. So that, you know, that isn't that helpful right now. But to help you specifically, what I would always say is that we can help anybody on this group and anybody else that you might know that's struggling to try and contact the appropriate services to raise your particular concerns, to see if those services can put something in place for you right now, even though we don't have that big solution available for the hospital yet, if that makes sense.
Yeah, I'm just going to say it's very difficult in the Leeds 26 area because getting social support is very much redundant in my area, and there are a lot of services, and I feel like the GP or all surgeries should be working with hospital. I mean, I used to be part of Leeds Involving People when we tried to restart the standards of how people receive information, and that people should be there should almost be a record of that anyone can access of people's needs before they went to an appointment anywhere.
Yeah, agree. I might not have articulated it very well with what I've just said, but that is exactly what we're trying to achieve. You're right, that is what we need. And I know lots of colleagues on this conversation from various different organisations are trying to achieve the same thing in their specific organisation. So we agree that is what's needed, and that is certainly what the hospital is working towards delivering. What I can offer you right now, Jane, we wouldn't do it on this call, but if you want to send me your details outside of this meeting, if there's a way of doing that, then Rosie and I would be very happy to go to those services for you and see if we can put something in place for you right now. So just so that you try and get that, we can give you that communication in the way that you need it to manage your pot and those kind of things that you've described today. The other point that I think is really interesting that you've brought up is the one about having difficulty when you're wandering around, when you're trying to move around the physical environment in the hospital, and I completely appreciate that. And I'll have a conversation with our head of nursing for our outpatient departments about that, actually, because it's a good point, well made. And of course, socially distancing right now really does impact on our ability to find ways to do that safely. But nevertheless, I completely appreciate the situation that you find yourself in, and that's not ideal. Just for your information in the background to assist with this understanding, really, not that it helps, is that one of the obvious solutions for that for me would be to introduce volunteers into those environments to help people right now. But as a trust, we're limited with the number of volunteers we can have working in the space right now. And there is for obvious reasons, to reduce the spread of this illness, we are making very clear decisions about reducing the number of people in our spaces. And that includes limiting the number of volunteers that we allow on our premises to keep everybody safe. But obviously that has a downside associated with it, because it means there are less people around to do things such as you're describing, Jane, would be helpful. And I appreciate they would be helpful.
At the moment, people don't know that I'm blind when I'm going into a service because I'm using crutches to get around. So I'm basically getting a taxi from place, and then I have to actually get through the hospital just by visual mapping. And it's really, really difficult. I mean, so if I'm going to a fracture clinic and they're sending me to X-ray, and the guy in X-ray is telling me, oh, I need to move my foot this way, that way, they have no idea what. And same with people with hearing loss. Obviously, people, it's not apparent at the time that people have hearing loss, and that they need sufficient help, especially with obviously with the masks and everything that everyone's wearing. It becomes more difficult to lip read for people.
Yeah, I mean, in a way, Jane, I think for me, whether somebody's got a hearing impairment or a visual impairment is kind of not irrelevant, but I think that's the kind of service that adds value to people in lots of different situations. It would be helpful for people who are confused. It would be helpful for people who are a bit older. You know, there are lots of people in lots of situations that would benefit from that support of being able to get around. And in previous times, we've had access to more help in those environments to be able to help people get around than we have now. But leave that with me. So I understand where you're coming from and the points that you've raised there. And it is right. We have changed the way our environments work. That is difficult for people who are used to moving around them in one way, and clearly can't do that now. So apologies. I'll take that on. I must take this phone call, actually. It's urgent, everyone, if I may. If you need any more info, could Rosie take it from here? Hi, it's Christine.
Will do.
Okay. Thanks, Jane. You've raised some really important points, which hopefully Christina and Rosie will take on, and people from the other agencies too can learn from that. I just want to pick up on one wider point, which bothered me a bit about what you said, and ask Hannah about this, which is, it sounds like the GP has labelled you clinically vulnerable in order for you to get additional support that when you're not actually clinically vulnerable, you've just broken your leg. And that seems a bit of a worry to me, Hannah. I just wondered if you could comment on that, what you think.
Yeah, I sort of had a query about that as well, Jane. I think, as Jonathan said, I think the GP's giving you that label so that you can access the food support, maybe because you haven't got the family support there at the moment because they're in their own bubble. But that doesn't mean to say that or we might need to just check the rules, but as I understood it, if you have a need for someone to support you with your health and care, then those people should be able to support you. So it shouldn't mean that you're isolated on your own. So it might just be, you know, we can pick up with you after this, Jane, but it might be that we just need to just check the understanding of what the GP sort of has told you about that, and around the rules around, you know, being able to see people or getting support to take you to the hospital for an appointment or whatever it might be.
I think the problem is the classification of bubbles. So my parents are in a bubble with my dad's parents because they're looking after them, and my sister is looking after her mother-in-law who has also just had her hip done. So it kind of like, and because I do have previous health conditions such as COPD, quite severe epilepsy, and I was struggling with the shielding boxes because I was getting milk sent every week, and I'm lactose intolerant. So he wanted me to, and it was the only way that I could get shopping to my house.
Yeah. Okay. Well, if we can pick up with you after this, Jane, just to check the details, that would be good.
Cool.
Julie, I think you were wanting to come in, Julie.
Hi. Yeah. The offer that we have to give to people is a really difficult one because of all the different systems that we have in the city.
Julie, can you just remind us where you're from?
Sorry, I'm from Leeds and York Partnership Foundation Trust. I'm the manager of the health facilitation team. So, as I was saying, the offer of flagging somebody and their needs is a really difficult one because we all use different computer systems around the city that don't talk to each other. The one thing that you can do is what we've sort of done for our teams in the city is, and our patients in the city, is we've created a reasonable adjustments care plan. So this care plan will say that, you know, you have a visual impairment, you prefer digital information rather than letters being sent. And what we ask for practices and health organisations to do is to log these reasonable adjustments as an alert on their system, because every service has an alert system. And actually, if a secretary is looking you up to get your address to send you a letter and she puts your name in, Jane, then your records come up and a box comes up on the screen of all computer systems if it's an alert So it's something that's really important that everybody needs to know. And it could say there, please don't send Jane a letter, please send her a digital message. That's a really simple fix for the issues that we have with the existing computer system. And whilst we wait for new sort of computer systems to come into play, which is going to take a long time, none of these things are easy. What we're also doing is working with Leeds Care Records. So Leeds Care Records aims to join up all the different computer systems with information so that the hospital can see what happens at the GP, can see what happens within learning disability, mental health services, etc. And we're asking for Leeds Care Records to put these alerts in one place on that system. So those alerts can be seen by all organisations that can access Leeds Care Records. So it's a really simple fix, but you've got to tell your GP what your reasonable adjustments are in the absence of a proper system at the minute. But that's available on our website. It's just one piece of paper, you fill it in, hand it to your GP, and they should log it in as an alert. So when anybody's getting in touch with you, when you go to a different department, they know that you've got a visual impairment, that you might need support to find a seat, things like that, things that are important to you. So that just might be one easy fix until the proper system comes into play.
My GP is aware that I'm registered deaf and blind. It just doesn't get carried on through the service, and because obviously now I'm not getting patient transport, because they're also aware of my needs. They're also aware that I do need to have someone come in to support me as well. But obviously that isn't happening right now. And it's the same with my nephews. I've got 3 autistic nephews who don't understand without having a face-to-face with a GP. They just don't get it. I mean, both of the youngest that we have have no speech at all. So yeah, it's difficult.
Yeah.
Thank you very much, Jane. There's some really important stuff there, some of which we can weave into the report of this meeting and the publicity that Tatum mentioned before, particularly what Julie's just said. We need to make sure everybody knows about how you can register things, even if it doesn't work quite right for everybody. But can we move on now to still keeping a focus on visual impairment? Has anybody else got any other different and additional things beyond what Jane has highlighted that they'd like to put in to the meeting at this stage, keeping the focus on visual impairment? If not, we'll move on to the next area. Dahlia, I've just been told you got your hand up. I can't even see it. Oh, there you are.
Hi. Hello. Hi. So as I mentioned, I'm a project manager in the City Digital team. It's the team that works with all health and care providers in Leeds and is trying to create projects that helps people essentially. And I just very quickly wanted to mention in response to Jane saying that it would be good to have a record of people's needs that's accessible by health and care teams. So we do have a platform in Leeds called Helm. It's a person health record. It's at early stages of development and not finished, sort of not as rich as it could be, but it does have a functionality that's called top 3 things about me. So you can record top 3 things and people record different needs, conditions, headache, diaries, anything, and then click share, and that information is then shared with Leeds Care Record. So Leeds Care Record was mentioned earlier today already as like a shared place where all the GPs, community team, hospital team can see the person's information. It's worth noting that, and it's in response to again what was mentioned, that despite you sharing that information, we don't currently have an alert that would notify your health and care provider that you've submitted that information. But we're working very much with clinicians and loads of other people to make sure that they regularly check the place where the information from Helm goes. So it's just a way of sharing, I guess, an alternative way of sharing your needs with health and care teams.
Okay, thank you very much, Dahlia. It seems to me we've got a really concrete issue there. when it's reasonable for us to expect, when we all get together in 6 months' time, that this will have been sorted. You know, I really think we ought to give ourselves a challenge for that. I can see Carl with your hand up, and then I'll come to you, Hannah. Okay, Carl.
Hiya. So just in terms of dealing with people with a vision impairment, one thing that I've heard some people speak about, but also I've had experience myself quickly, is when going into GP surgeries now, because people are keeping a greater distance, so staff are keeping a greater distance and wearing face masks, the sound is very, very different. So people who rely a lot more on sound can end up struggling to hear clearly. And also, because there's a greater distance between two people, it can be hard to know that whether people are, staff are actually talking directly to you. So I just had this experience last week. So staff are saying things, but it sounds like they're just shouting it out to the whole room rather than specifically talking directly to you, which of course normally wouldn't be a problem because you'd normally only be a couple of feet apart facing each other. So just to say that if people can pass on to staff that they're going to have to be a bit braver when wanting to tell a blind person, they're going to have to, if they don't know the person's name, so they see, say, me walk in with a white stick, they're going to have to find a way of actually saying something out loud, like, I hate to say this, but hey, blind person. I'm sure people can come up with better ways of approaching it than that. But effectively, you really need to find a way of saying, oi, blind person, stop where you are. You're going to need to move left, right, forward, back. So it's just about being braver and a bit more upfront and not worrying about necessarily offending people, to get in there and get people in the right place.
Okay, thank you, Carl. That's absolutely fascinating. Something I'd certainly not thought of before. Hannah.
Yeah, I suppose just to pick up on your point, Jonathan, about action, there are a number of groups in the city that are looking at the reset of services and health inequalities at the moment. And so I suppose it's just really this group really taking forward the issues that we've heard today, so that those issues are taken into account. I mean, obviously, Christina's here, Heather's here, Sharon's here from partner provider organisations to feed that in as well. But you know, I think I think what Jane's experiencing, it's such a good example, and thank you very much for sharing, Jane. You know, really illustrates how issues in terms of accessing services was an issue before COVID, never mind with COVID, and as a city, how we put in a priority on that in terms of being able to access services. So I suppose it's a commitment from us as well at Healthwatch to really take forward those conversations wherever we go. And as you say, Jonathan, to see a plan and action around that. And I'm just conscious of all the conversations around the Leeds Care Record and Helm, but they're all longer term actions. It's what's that shorter term action that we've got in the city to make services accessible now, really.
Okay, thank you very much, Hannah. I think now we need to move on to the experience of deaf and hearing impaired people. And I know there's a few people got some experiences there. Who would like to start? Okay, Howard.
Howard, yeah, could you just give me just 1 second to pin Howard? Oh. Tatum, would you be able to pin Howard for me, please? I mean, Spotlight.
Oh, Spotlight, yes, of course, yeah. I won't be able to pin, but I can certainly do Spotlight for you, no problem.
Please, if you don't mind.
Yeah. There you are. Can you see that properly? I think both of you are Spotlight now.
Okay, Howard, you can go ahead if you can. Mel, are you all right? You can see okay?
Hold on.
Can you see, Melissa?
Yes, I can, thank you.
Okay, you're welcome.
Howard's having a problem now, bear with us. Okay. So deaf experience in terms of going to GPs or hospitals, I've had a lot of feedback about the screen. So the screen can affect the reflection specifically from the screens, depending on what is actually behind the person. So if that's a glass door, if there's sun behind, how much light, it's quite difficult to be able to see. That's one of the difficulties. And also the shield that people are wearing across the face, they're very reflective as well. They have to sort of move and avoid any reflective surfaces. Those are the two things that affect communication. We've already mentioned in the past about masks. I don't need to raise those issues. But the actual screens that are being put up and the actual shield that staff are wearing, those are causing a problem. I don't know whether there's a possibility of non-reflective screens, or because there's always quite a heavy shine on them, and that can affect communication. So that's something that the community have fed back to me that I thought I would pass on.
Okay, thank you very much, Howard. That's really useful. Alison, have you got anything, particular things you wanted to raise?
Let me just pin her, bear with me. Okay. Yes. Sorry, she's highlighted herself. That's not what she wanted to do. Okay, so my mum and dad are deaf. My two children are deaf as well. So we have a lot of experience within the family. Personally, I went to my GP surgery and I had to stand outside pressing the intercom system. And then I was spoken to, so a person behind me actually saw that I was having these difficulties, but they had a mask on, so it was hard, and they were sort of indicating, but obviously it wasn't their responsibility, so I just pressed the intercom again, and I think they were trying to tell me that they knew I was there, but obviously I didn't know that, so I just kept on pressing the bell. And a woman like behind me was sort of indicating, I think she was trying to say they know that you're here, but I mean, I had no idea of that. So eventually somebody came wearing a mask, and I was able to explain that I'm deaf. And that we sort of got the gist of things wearing the mask, that somebody was going to come down. So I stood to the sides. And I think when they realised I was deaf, they just sort of stood back, lifted the mask down, and then they were able to sort of explain again. But it's happened on more than one occasion where I've had to constantly press that bell, because even if people are trying to tell me that they know that I'm here, there's no guarantee that that's what they're actually trying to say. So that's one point. But then in an appointment with the nurse, she actually found one of those, you know, where they have a window, where they have a window, and it was quite difficult because I couldn't see anything. But in the end, because of all the steam and the condensation, in the end, we just sat and we actually had to write down everything.
Okay.
Alison, hang on. My sincere apologies, but for some reason Richard's appeared on my screen and Alison's disappeared, so I can't see her.
Shall we just do the swap over then? I was kind of waiting for a moment to get in, so we'll do it now.
Okay.
Can you see Alison? If not, I can spotlight you both so that you can see everyone. I mean, sorry, Richard and Alison can see each other. That's what I meant.
Yes. Yes, Tatum, they can.
Yeah. Okay. Oh, fantastic.
Yeah, so we're just going back to a hospital example now. The hospital had made several phone calls to her, which she obviously couldn't understand from a number, just didn't know what it was. Kind of thought it would be pertinent to an appointment she had later, but didn't really know. It was just kind of guesswork that this series of incoming calls was about an appointment. Didn't know if it was to say it's been postponed or cancelled. So sort of tried via the text phone service, tried to sort of get in contact that way. But you know, it's a number that can only kind of phone out, really. It's you don't kind of know where it's going from. So phone calls from the hospital, they kind of just come from a generic number that you can't kind of return back. So just trying to sort of find out what all this was about was very hard work. You know, trying to know which department is this phone call emanating from or anything like that. And you just have to kind of get through to somebody, trawl it through the system to try and work out what it was about. No idea really. So yeah, I knew it was something to do with a hospital appointment, just to kind of make sure if it was still going ahead or not. But anyway, so I did actually end up just going to the hospital appointment. Drove there, and you had to kind of pay for your parking via an app as well, which was a bit difficult. But yeah, so yeah, the parking system's changed. You pay for your parking via a phone app. Anyway, it took a while to sort of do. You need to kind of it was a palaver was this. Anyway, there were other people having the same issues trying to do that. Anyway, we got that sorted. So went in. Can we just slow down a little bit, please? Can we just slow down a little bit, please? Thanks. So went in, and there was the glass screen, and it kind of tried to explain that I'm deaf. I slid the appointment letter underneath the screen for them to see. They had the member of staff, the receptionist, had a look on the computer system. They sort of scanned something or sort of highlighted something, and it turned out it had gone on the wrong day for the appointment. It was in 2 days. I was 2 days early for the appointment. I kind of thought, oh, don't know about this. Checked, sort of checked if it was still on, and they sort of didn't know it. They didn't know it was actually in 2 days' time. So anyway, yeah, so that was sort of maybe what the phone call was linked to. Tried to contact the PALS service about this as well, just to kind of explain. Sent an email to them saying that we got all these phone calls from this number, couldn't do anything with it, got a letter sent through, didn't know what to do with it. So this has sort of been all passed on to the PALS. Oh, okay. Sorry, can we just go back? Something popped up and it covered your hands. Sorry. That's better. Okay. So emailed the PALS system about these two things. The first one I sort of let them know about was the phone calls that I couldn't do anything about, and then the letters, and sort of arriving, and there was no interpreter as well. So, you know, kind of wanted to make sure in advance that the interpreter had been booked. And when we sort of got there and said, I need an interpreter, they didn't seem to know anything about that. They didn't know I needed one. You kind of think, oh, this is the 21st century. How are we sort of still in this position of you not knowing all of this? So sent all these off to PALS for them to have a look into. So, yeah, eventually sort of did go on the right day to the appointment. And the receptionist, when I got there, the receptionist said where to sit, and to make sure you're kind of socially distant from each other. A nurse came round. She had the face mask on and started talking away. I could tell she was talking because the mask was sort of fluttering away, so I could tell that she was speaking. But nobody else kind of stood up to go with her, so kind of realised by default it must be me that she was after. Explained as how I was deaf and showed her the appointment letter. So ended up following this nurse through to another room. Again, she started talking and just tried to explain to her that I was deaf, and, you know, couldn't see, you know, she just kept pointing at the mask. I said, I'm deaf, I can't understand what you're saying. Can we sort of write things down? Or so we did have to kind of write stuff down ultimately. And she wrote down on a piece of paper, can you lip read? I thought, so wrote back saying, yes, but I can't see you because, you know, you got the mask on. So she sort of read this reply that I'd wrote back and then eventually put 2 and 2 together. And at the same time, the phone was going, and it was the hospital again, you know, whilst I was in there. So passed the phone over to the nurse, who didn't sort of know what to do really. She went off. So just ended up answering this phone call and shouting into it, "I'm deaf," and then terminated the call. Eventually, then the nurse came back. She sort of put her mask and glasses down, and she did sort of pull the mask down, and we sort of talked a bit. It was only a brief appointment anyway. But go back to the 21st of October, or no, oh, so yeah, there was about 18 phone calls or something, or from a Leeds number. It was, and then another one was from like St. James's. So numerous phone calls again and again and again. One was sort of through the LGI. Did a video call with them. It was. Yeah, so the LGI had got a system where you could contact an interpreter and then they could video call a deaf person. But the doctors, not so much. On the records, on the hospital systems, it should say, I may double check, but it does say that I'm deaf, and that is logged on the hospital's own system. But it doesn't mean that there's any kind of automatic booking of interpreters. Even though you're registered as being a deaf person, it then doesn't automatically generate an interpreter booking for appointments. So there are a few more issues, but I don't know if anyone wants to kind of raise anything from the back of that.
Okay, thank you very much. Some really, really serious and worrying issues there, which will need to be picked up. I just want to go to Jason, because I know you've got some things that you wanted to put in as well at this point, and we are running a bit behind time, but I think it's really important to get this information out and on the table, so we'll stick with it a bit. So Jason, can you add your experiences to that as well, please?
Sorry, can we just, if it's a deaf gentleman, can we just pin him, please?
Is that okay now? Can you both of you are spotlight now?
No.
No. So
I'll do it, don't worry.
Sure, thanks, Mel. I'm on the phone.
Go ahead, Jason. Jason, go ahead. Yeah. Sorry. Oh, I can't see the interpreter now.
How about now?
Yeah, that's fine. Thank you.
You're welcome.
Oh. When you spoke, then he disappeared. Sorry. Okay. So 2 points, well, 3, but I think Alison's covered the third, so perhaps just 2 points. That was a marvellous example of all the issues, but it's just like that point. So the 2 things that I wanted to raise, and this is just a recent experience, and I don't know whether, I don't know if it's a conflict of interest in terms of using interpreters from the Deaf Centre, because it was linked to the same service. So it was linked to masks and social distancing, but this is a specific example of a patient that went to hospital. They had an interpreter provided, but the hospital did book the interpreter, but the deaf person wasn't sure what the diagnosis was during that appointment. Can I just clarify that? Sorry. Do you mean that they misunderstood the interpreter? Right. So the patient themselves, because whether it's because of social distancing, the actual situation itself, the fact that people were wearing masks, that kind of thing, it's not a normal situation. So in this particular setting, the patient just didn't understand the diagnosis. I mean, they have the ability to understand what was happening, to be able to, you know, identify medical diagnosis, but they didn't realise, they didn't get that in the appointment, they didn't get that information. And it was, I've no idea really in that situation why that communication broke down, what those problems were relating to, whether, like I say, it's the situation at the moment. But it is vitally important that a patient understands the information that's being given to them, and whether that's the responsibility of the doctor or the interpreter to make sure that the patient fully understands what's happening. So it's a duty of care in terms of the interpreting service to make sure that translation is clear and that the patient has fully understood the information that has been given. So the doctor obviously passes on that, and then the interpreter translates it. Jason's just saying that he's worked with that patient before and they have the ability to understand the information, they have the ability to take in that information. So that's quite worrying that in that situation, you know, communication broke down. So that point's finished. I don't know how you solve that situation. I don't know whether that's a discussion with the interpreting service. I don't know if it's the right time to bring it up. Like I said, because of the conflict of interest, because we've got 2 interpreters from the same service on the call, so not sure.
Okay, I think what you're raising, Jason, is something that came up quite strongly when we had the big meeting in Leeds, when we were all able to be face to face about how do deaf people know that if they've got an issue with the quality of the interpreting, they can raise that and make sure it's properly investigated and dealt with. And it sounds like that didn't happen in that case. So I think there's an issue we need to take back into the commissioning of how these services are done, because we made that point very strongly. I can see Alison has her hand up, but I just want to check, Jason, whether you've got anything else that you want to add to that. So if you could just hang on for a moment, Alison, please. Jason, have you got anything else?
I have one more, but it's not related. It's just related to COVID. It was a COVID issue.
Is it?
So I think we'll go to Alison. She's more, I think that's, yeah, she's probably got a more relevant point.
Okay, thanks. Alison?
Okay. So when a deaf person goes to an appointment, and so for example, my mum and dad, who are both BSL users, my father doesn't have a full understanding if the interpreter's using BSL. So in some ways, my mum has to sort of intervene in that situation and offer examples and assist in the communication. So it's almost like she becomes an advocate in that situation for my father. Sometimes my mum understands everything, and then when she gets home, she realizes my father hasn't understood. So she has to sort of go through all that information again. So it's like, it makes you wonder how many deaf people out there are in that same situation. I think sometimes, depending on the person, you need to offer a deaf interpreter as well, who is able to adapt the language suitable to the patient, because not all deaf people use language in the same way. There are lots of different, there's a huge diversity within the community. And so how I communicate with my mum is completely different to how I communicate with my dad, and I'm able to, you know, adapt that. So it's just, it makes you wonder really how many people are struggling, and especially if the deaf children have got hearing parents, in a health situation, it's quite important that they get that information.
Okay, thank you very much, Alison. That's covered in terms of the experience of deaf people. I think we've got an awful lot of detail and richness of experience there that hopefully can be picked up and dealt with, and we'll make sure is clearly recorded in the notes of this and the publicity. Is there anything else to do with deafness and hearing impaired? Oh, I think Caris, I think you wanted to come in, didn't you? Sorry, I've just missed that.
Hi, yeah, just a couple of things to say. The first thing is in relation to Jason's point. Actually, yes, this has been investigated. It was raised to me, and actually there is some disparity in terms of what's been explained versus what was investigated. But I do just want to reassure you that yes, it has been investigated and responded to. So it's just to put that out there, really. I think with us being short on time, it's probably not one to kind of go into great detail about. But actually, I think there were two types of appointment. I think there was some misunderstanding in terms of actually what happened at the appointment and what was then sort of said. So it has been investigated because I investigated it myself. I think just to kind of move on, but in conjunction with that, in preparation for this meeting, myself, Carl, and also Andrew from Deaf Blind UK had a bit of a collective conversation because we thought it might be helpful for the organisations if we fed back collectively today rather than individually. And I think one of the kind of points that we identified as being a challenge at the moment is mask wearing, which is what links in to this particular case. And I think it's very difficult at the moment because during face-to-face appointments, masks are needing to be worn, as well as visors, etc. And I think there's quite a lot of sort of feeling from people that perhaps interpreters shouldn't be wearing masks, or staff within the organisation shouldn't be wearing masks at times. Actually, we need to do that because that is firstly protecting the staff, secondly protecting those around, and that is the directive that's there at the moment. So if we're able to pull masks down to help with communication, we are doing, but we can only do that in certain circumstances. Additionally, one of the things that we're encouraging at the moment is very much video interpreting where possible, because obviously then no mask needs to be worn, and ultimately then for somebody who does want to lip read, it's much easier to understand. I think we all felt that the masks are challenging, not just for members of the deaf community, but for the blind community as well, as Carl explained earlier in his point. We had got a couple of other examples whereby people have attended different areas, be it hospitals or GPs, and haven't had interpreters provided for them. And we've also had examples of people who've attended GP practices and been asked to or suggested to organise interpreters and things like that. So we've had a few examples with relation to that. The other point that I wanted to make was just in relation to Alison's feedback. This is something that's already been picked up by the Teaching Hospitals Trust, who've actually asked to take some of Alison's points, work together and look at ways that that can be used in their action planning. We've done something similar with another gentleman who attended on this call, and it's been a really successful way of seeing how those feedback points can be taken and then can be introduced into new actions and things, which has been a really positive thing. So I just wanted to kind of highlight that there's already work in progress there to take on some of those points, which is fantastic. And I'm just skimming through our other points. Carl, I don't know if there's anything you want to mention that I've not added in.
No, just to confirm that the feedback that I'm getting about so this is GP appointments and booking of interpreters, so not hospital appointment interpreters, but GP appointments. There seems to be real confusion about how to book an appointment. That's by staff at GP surgeries. So I've got a client at the minute I'm dealing with, a GP surgery, where they've booked an appointment but then told the client to effectively book the interpreter. Well, there's no tying up those two things, so that when that client's then going back, sometimes there are just no interpreters, and obviously staff aren't 100% sure how to book an interpreter for a GP appointment in the city. So there's definitely confusion from staff, and because there have been recent changes on making sure that interpreters are definitely confirmed to be booked for a GP appointment. So it's not just a case of sending out, asking for an interpreter to be booked. It needs to be absolutely confirmed that that interpreter is going to be available, whether it's face-to-face or video, on the day of the booking. So that seems to be a problem at the minute.
Okay, thank you, Carl. Now I can see one or two people have got their hands up, but I think we're going to have to bring this part of the discussion to a close. We were supposed to be focusing on learning disability as well. The people who are going to do that haven't come to the meeting, but they have sent some written information in, so we will pull all that together. So what I'm going to suggest now is we take a break. It was supposed to be 15 minutes, but I suggest we have 10 minutes, come back, move on to the agencies, but there will be an opportunity as the agencies talk about what their plans are over the next 6 months for people to pick up and question that as we go through. So I hope I think we've got an enormous amount of really important, and I must say rather depressing information out so far, and we're going to move into hearing in a bit more detail what's going to be happening over the next 6 months. I'm sorry if not everybody's had a chance to say exactly what they want, but we've got lots of information there. So it's 11:15. If we come back at 11:25, please, and we'll carry on with the next bit. Okay, we're now going on to hear from agencies with an update about what they're focusing on, what their priorities are, particularly over the next 6 months or so that when we come back in May, we've got some anchor points in terms of measuring what's happened, what's in place that isn't there now. And I know all the agencies have been talking about how Accessible Information Standard has risen up their organisational priorities. So it's going to be interesting to hear what's being said. Now, the first agency is Leeds Council, and unfortunately Elaine Ray has had to give her apologies. Something urgent came up just before the meeting, but I think, Tatum, you said that she sent some information to you. Is that correct, or is there anything you want to highlight from what Elaine has said?
Unfortunately, she hasn't sent it yet. I think she was going to give the feedback in person, but unfortunately she has to give her apology. But as soon as I get the update from her, and now we will circulate it to the group, or use that information to plan the next 6 months' work. Okay, that's fine. I've just seen a message from Alison. Can Caris be unpinned, please? Has that happened? Caris has already been not on Spotlight, but I think it's because Alison pinned her, so she has to do it herself, I'm afraid. Okay, so can we go on to Leeds Teaching Hospitals Trust now? Christina, are you there? Oh, yes.
For our update, Jonathan.
Yes, please.
So I feel I've spoken quite a bit already this morning about the type of work that's going on in the trust right now. So in terms of being able to address some of the problems we heard earlier that were very eloquently shared by people on the call, one of the main things that we do see has to be put right in order for experience to be helped for people across the board, is this issue of being able to sufficiently record and flag information. So we've heard some examples where people are quite sure that their records do contain information about their sensory impairments. However, the reality for our clinical teams as people move from one service to another, and lots of different people are involved in their care from an administrative perspective, from a clinical perspective, is that realistically what we need is a functionality that allows everybody who interacts with a clinical record to be made aware, to be absolutely made aware that that individual has got some particular support requirements. So we're looking for a system that would actually flag up and very visually alert the user that actually the patient in question needs some support. We don't have that in place, and that is one of the main things that we are working on. So when that is in place, as I say, there is a big upgrade, a big digital upgrade that has been prioritised for exactly this reason, because we recognise in the organisation that what we have in place is not good enough and we need to get better. So that has been prioritised for the beginning of next year. The work is going on now, but it's such a big piece of work that it's not expected to be completed until January. I am working with the project manager who's involved in that piece of work and having a conversation with her this week. So she's been sourcing information from lots of specialists and is coming to talk to me this week just to make sure that this system, when it's up and running, is likely to be able to deliver what we need it to deliver. And actually, all the information that I've heard today, this has come at a really timely point for me, because it is information now, absolutely, that is live, it's current, it's talking about people's experiences right now. And I can absolutely feed that into that conversation. So actually, I'm really pleased about that. That's one of the big deals that we've got. The other issue that I've heard a lot about today, we're absolutely right. You know, it's a really important point, isn't it? Fundamental to people's ability to access our healthcare services is this issue of interpreting. And so we've worked hard, and we continue to work hard with Charis to get our interpreting service right. So one of the first things I wanted to say is that I meet Charis regularly as part of contract conversations. So we are the owners of the contract for the interpreting service that is delivered in the hospital. And absolutely, I would just like to get a message out there that if anybody has issues with the interpreting service in terms of the hospital experience, the right thing to do is to send that information to me and my team, because we have those regular conversations, and then Charis and I get together around at those times and are able to investigate what's happened and make sure that we're providing the right service for people in hospital. So please do always consider letting me know and letting my interpreting team know if you've got an issue, because there are ways we can help with some of that. So that's really helpful to share, I think. The one thing that's not going to be very easy to hear, I don't think, but I do feel it's the right thing to say to you all right now, is that a recent decision has been made, and this is hot off the press, this is in the last couple of days. A recent decision has been made to be really careful about booking face-to-face interpreters anymore in the organisation for use in the organisation. And that's because we are massively worried about the number of people who are in our hospital environments, because it is a potential reason why COVID-19 spreads. So actually what we need to do, the right thing for us to do clinically in the organisation is to really consider where we have people in our environments that we can try and eliminate from those environments. I know that's a harsh way of putting it, but actually the bottom line here is trying to keep patients safe and trying to keep visitors who do have to come into the organisation safe, and of course staff. So that's why we've made a decision to limit the number of volunteers, and that's why a decision has just been shared on Friday that face-to-face booked interpreters will no longer be used in the organisation unless there is an absolute clinical need for that to happen right now. Clearly, because of that, we are looking to work very closely with our interpreting providers to ensure that there are other solutions available. So we will, for the interim, be using video interpreters, and clearly continuing to use Carison service in a different way. So that's hot news. It came out on Friday, and you're hearing it first, really. But I thought we have so much conversation today about interpreting. It's a really important thing to put across, because I know that decision in itself might complicate the scenario around interpreting even more for some of our patients for a short while. But it is what we have to do just to keep our hospital environments safe. I will just come back to you in relation to some of the comments that were made about mask wearing. We've said it on this call, but it is absolutely right. The clinical situation that we're finding ourselves in the hospital in right now is such that we need to wear masks. It's not appropriate for us to be operating in situations where we don't wear masks, and I absolutely know that causes difficulty for some of our patients who need access to see people's faces. We have trialled the transparent masks that are available to us, and you know, in common with what has been said here today, we know they're not clinically viable, so they don't meet the clinical requirements of masks to keep our staff safe. So we can't use them in highly risky areas. But we're finding that even when we do use them, they are problematic with condensation and those kind of issues that people have identified today. But I just wanted to assure you that, you know, we are continuing to work closely with our procurement, our supplies colleagues, actually, to see if we can come up with identifying a mask that is clinically safe and is better for communication purposes. So just to say that, I will just share as well with you all that from a learning disability perspective, Alison Conyers couldn't be on the phone, on the call today, but she has asked specifically that I let everybody know that the Learning Disability and Autism team have changed their ways of working and have massively increased the number of visits made to patients over the last couple of months. So she just wanted to share that message that care continues to be available for anybody with a learning disability and autism who needs it, because she's understood from some of the community that people have understood that care is not being made available for whatever reason. I'm afraid I don't know the detail behind that, but she just wanted to make sure that I shared the message. Care is still available and we are doing our best as a team to make sure you are supported through the care that you require in our hospital environments. So I'll just put that forward as well. If there's any questions for me, do let me have them, guys. I'll just have a quick look on the chat here. Yeah, Alison says interpreters can be provided via video call. Absolutely, technology is here to do that. It is. I feel sometimes sad when I'm involved in these conversations, and I know that video technology is a solution to it, that it appears that not everybody is aware of that, and I know absolutely there are ways to access video technology for anybody who needs it when they come into our hospital environments, and any work that this group can do actually to raise awareness that those facilities are available, it'd be really helpful. Finally, I'm just going to say, because Rosie did put a little note into the chat around this, our PALS service have now introduced a text phone specifically to enable people to raise concerns via text. We haven't seen it used greatly. It's something that the deaf community particularly have asked us for. We've put that in place now. I hope that means there are no concerns, but realistically, I don't think that's likely to be the case. But again, publicising that with and for us would be really helpful. Facility is there. It's a really good way to alert us that you need support.
Okay, thank you very much, Christina. Rosie, did you want to come in on that?
No, I think it was precisely that. I just wanted to draw people's attention to the PALS phone and say that we haven't had a lot of traffic via it. So please, 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 as Christina says, make sure that everybody knows that it's there. The PALS team will be able to, I mean, typically you get a telephone call, you don't know who it's from, they will be able to find out who it's from for you and get back to you and let you know, and also let the service know if you've got any specific queries or questions or needs that you want to draw their attention to.
Just as an interpreter, can I clarify, when you say text phone, is it a mobile to text on or like a Minicom style phone? Can I just clarify, please?
It is just a mobile to text on, yeah.
Thank you.
Okay, thank you very much. Does anybody want to pick up anything about what Christina has said before we move on to the CCG? Or anybody else want to pick up on any? Okay, right, let's move on to Sharon at the CCG.
Yes, hello everybody. Again, it's been a very interesting morning so far, and lots of really good information. Helen Butters is also from the Clinical Commission Group, so I'll cover what I think are the key points, but Helen might want to come in as well. So as a Clinical Commissioning Group, we, as many as you will already know, we don't actually provide healthcare services, we commission healthcare services across the city. We continue to work with, or I do, with our contracting team and quality team in terms of the processes around assurance relating to the Accessible Information Standard. At a previous meeting, I did mention that we had just reviewed our Accessible Information Standard Working Group and developed and launched a new Access for All group that has a much wider remit and has a much bigger membership from colleagues across the organisation. And I do feel, although we've only had 2 meetings, I think the group will be able to start to make real differences in terms of ensuring that our commissioned healthcare providers are accessible and meeting the requirements of this for the standard. One of the main discussions at the last meeting, and the focus was particularly around GP practices and primary care. We recognised as a group that there were still a lot of improvements perhaps that needed to be made across GP practices in Leeds in relation to asking patients their access requirements or what reasonable adjustments they had, and then actually recording them. So we're working as a group with colleagues that work in our IT department and work with GPs on their patient systems. So one of them's called System 1 and the other one's called EMIS. And we've already identified a number of areas of improvement which are being implemented at the moment. At the same time, a bit like the colleague from LYPFT, where we've just initiated discussions with Leeds Care Records, because again, we recognise that that's an excellent sort of platform that all health and care providers use, where people's reasonable adjustments or access requirements can be recorded and therefore accessed by everybody. We've also got plans over the next six months, again focusing on our primary care GP practices, to revisit the practice managers meetings, again to raise the importance of the Accessible Information Standard and share some of the experiences we've heard at this meeting and previous meetings, for example about the intercoms at GP practice at the moment, and obviously people that are deaf or hearing impaired not necessarily being able to hear the response from the people in the practice. We've also identified a number of e-learning packages that we will share across GP practices in Leeds, and we do plan to attend Target. Target sessions are regular training sessions for GP practices across Leeds that would normally, prior to COVID, be done face-to-face, but now we've got they're now set up to be done virtually. And I think they are the key things at the moment that we are working on. As I say, I do think the Access for All group within the Clinical Commissioning Group is going to be a a key sort of vehicle for us to really improve the access and experience that people have across Leeds in relation to accessing healthcare. Do you want to add anything, Helen?
The only thing that I want to add, which I don't know whether you've said it and I just missed it, was at our last meeting, we had somebody who came to talk to us about the digital systems when you go into a GP practice and they're recording your details. And one of the things actually that was highlighted when we were asking him loads of questions was around the fact that when you're actually inputting people's accessible needs, there needs to be a mandatory box, which means that when a new patient comes into the service or you're taking details from somebody, you have to ask those accessible questions, because what may be happening is people are registering or people are telling people their details, and sometimes due to error it's not been put on the system. But if you had a system whereby it, you know, there was a mandatory tick box to say that you have to ask every person if they've got accessible needs, and you can't move on until you tick that box, you know, you're more likely to record accurately. So I think that was quite a really important moment at that meeting. So we're going to kind of, look into that more, aren't we?
Yeah.
Can I just, Sharon, I was interested in what you were saying about the target sessions, the training sessions, and I wondered if there was scope to actually involve people with lived experience in those sessions, so that actually practices are hearing directly from people who have been standing there pressing the intercom button and not hearing what's happening, because I think that's much more powerful than people being just told that it's happening.
You're right, Jonathan. Definitely, that is an excellent idea. And what I will, with the target sessions,
sorry to interrupt. My apologies. Alison can't see the interpreter. Tatum, if you could spotlight, would that be okay?
I have already spotlight you.
Okay.
But I have already spotlight all the speakers and yourself, but just check whether Alison can see it first. Okay then.
Okay, carry on, Darren.
Yeah. So with the target sessions, target is an acronym for something, but I've no idea what it means. But it's the training sessions anyway. You know what NH is like for acronyms. Yeah. So and I do know, having past experience, they're quite. You have to put an application in to say what you want to attend for, and I do know the waiting list is quite long. However, that doesn't mean that I won't put an application in. So I think it would be good if I get the relevant documentation and fill it in, if maybe Tatum or somebody from this could then maybe add to it about the having people with lived experience, because I do think it is much more powerful than me just going and telling them that they need to do X, Y, and Z. If people at those target meetings that work in those practices hear firsthand that lived experience and the impact of them not doing perhaps what they should be doing has on individuals, I think it's much more very, very powerful thing. So I will do. I'll start that process in motion, and then I'll get in contact with Tatum, and we can maybe add to that with people with lived experience attending that session, just with the caveat that I think it will be accepted as a request. It might not happen straight away because of the pressures on target sessions.
I know that I attended the accessible information training that Carl was talking at a couple of weeks ago. And I think something like that at a target would be amazing, because that was really succinct. It was really powerful. And I know that lots of people got a lot out of that training. So if we could try and reflect something like that, but on a much shorter time scale, I think that would be really, really powerful target meeting.
Hi everybody, I'm back. I lost the end of what Sharon was saying. Had you finished, Sharon?
Yes, I had. But then Helen's just reflected on an accessible information standard training session she went on that Carl delivered. Is that right, Helen?
Yeah, I was just saying that I attended about 2 weeks ago the accessible information training that Carl was talking, and something called Christine was talking at, which was really succinct, really powerful. So if we could try and duplicate that, but in a much smaller timescale. Obviously, if it goes to target, there wouldn't, you wouldn't have the amount of time. I think that would be really, really useful to do similar, but at a target.
Just sorry if I could just chip in. So I did that training. We can provide that. We've done it for the DWP, and we provided it in about 20 to 30 minutes. It's really fast. We can do it very fast. Pile through it if people need be, and they can have that for free. Just have to give me a shout. Anybody can have that.
Yeah, we'll do that, Carl. Actually, that probably would be really, really, really helpful.
Okay, thank you, Hannah. I think you had your hand up just before, did you?
Sorry, yeah, just building on that. I mean, we many of us here on this group are members of the People's Voices group, which is all about putting people's voices at the centre of health and care decision making. It just feels like there's a message to go out in any of the sort of the reset of services, design of difference in the way that people access services, to do that with people with lived experience. I think the doorbell example is such a good example of that, isn't it? It just, of course, it doesn't make sense, but maybe people, if we work in partnership with people with lived experience, we'll get better outcomes. And I suppose just to say as well, the examples that people have shared today, I can think of a number of groups that it would be good to share. So I know we've recorded it, and I think people said they were happy to record it. But if people were happy for us to share the stories that they've told today as well, that would be really useful.
Okay, is everybody all right with that? Happy for it to be shared? Yeah. Okay, that's great. Thank you. Okay, I think we need to go on now. Leeds Community Healthcare now. Heather, I think, is gone and was going to share what she was doing in the chat. So I don't think there's anything else to add from Leeds Community Healthcare Trust at the moment. So can we go on to LYPFT, Leeds and York Foundation Trust, Partnership Foundation Trust?
Thank you. Morning, everybody, and thank you, everybody, for sharing their experiences. Much appreciated. So in terms of some of the feedback, I think Helen's already mentioned the wonderful training session we had with Carl. So all due respect to Carl and Christina for providing such a powerful patient experience and journey. And I think, as Hannah said, and I think as Sharon has mentioned, I think training for us as part of restart and reset, I think he's a wonderful opportunity while some of the services are coming back from hibernation is to get some training for staff. So that's one of the areas that I'm looking at within the trust. Also, in terms of, we've got some online equality and diversity training, and how can we build AIS into staff training, and how can we make that much more powerful than that it is at this moment in time. I think for me, in a nutshell, I think what I want to do is just capture what people have been saying. So the medical model is more about what's the matter, and I think we've already discussed the social model, what matters to you, and I think that's the question that we need to be asking as organizations, and that's some of the work that we're doing, and this needs to feed in to our engagement and inclusion plans as well, for each organization. I think in terms of the feedback, it's been absolutely wonderful. We have been, and Julie, who's on this call as well, if you don't mind coming in as well, we've actually had a discussion with our new system of recording called Care Director. So I had a meeting initially with the Care Director lead. So the Care Director is in 3 parts. One is it stores people's personal records. It also stores a person's care record that moves from one service to another. So whether it's outpatient, inpatient, community or other. And it also has demographics as well. And also it has various buttons around whether somebody's got an allergy, etc. So Julie, do you want to share something around learning disabilities? And I think you've already shared how within the city you store records, but do you want to just come in for the learning disabilities perspective? If Julie's still there.
Julie? Sorry, I forgot. Yeah, sorry, I forgot to unmute myself. So thank you, Saeed. We're just trying to make it. I was just typing a message actually to Helen and Sharon Moore about the CCG offer. So what services quite often do is they'll say, oh, we're offering reasonable adjustments, but for a patient with a learning disability, they might not understand what a reasonable adjustment is. And quite often when you're asked something that you don't know about, you will say, oh, I haven't got any, I don't need those, without realising that it's something actually positive that can help you. So within our service, we are using our reasonable adjustments care plan to try and get staff to make that entry onto the computer systems. That means that any department within our service, or that if that goes onto Leeds Care Record, any other organisation can support people with a learning disability because they know their reasonable adjustments prior to them attending an appointment. So they can make those small changes that would make it easier for that person to interact and engage with a health service. So we're desperately trying that. And I'd really like to work with Sharon and Helen about what you're doing in GP practice, because a lot of my work focuses on training and supporting general practitioners to engage people with a learning disability. What I don't want you to do is forget that the offer needs to be accessible to a person with a learning disability when they go to their practice. So that would be a really good piece of work to work together with that and get that tied up for people. Thank you, Saeed.
Oh, no, much appreciated, Julie, as well. And I think for me, right, in terms of, I think what the gentleman mentioned earlier on around the duty of care for organisations, I think the onus and emphasis around accessible information standard falls completely to the trust. So it's down to the trust to ask the individual in their particular format. It's to then record and then to provide that relevant accessible service. So I think we all need to be very clear about what our duty of care is and what our offer is as well. The other thing, the other points that were mentioned earlier on was around flyers and promotion materials, etc., being made available within services. And I think that's really important as well. What we've tried to do, and obviously through COVID, the scale and pace of the refresh around AIS at LYPFT has just basically slowed down in particular areas. It's been quite rapid, but in terms of getting flyers and publicity material within services, that's been quite slow. So that's something we'll be picking up as well. Those people that have navigated onto our Easy on the Eye portal within our website can find a lot of easy read information and also the accessible information standard, the 5 core steps: ask, record, highlight, share and act as well. So what we're doing within the organization is working on each point. So the first starting point, and I think this is what Carl mentioned in the training, which is really, really important, is to understand the individual's preferred information and communication. In order to understand that, you then need to record that on a system. Now, within the Accessible Information Standard, it actually gives you options whether you record it on a system or whether you record it on a paper. The third bit is how you highlight that and how you share that within the system. But I think Julie's already mentioned, and other people have mentioned, the Leeds Care Record as well. Now, whilst we within the organisation will try to make sure that there is information within our services internally, we also need to share these records externally. So the individual is not asked the same question over and over again, and that their records are stored. So that's very, very important. I think going back to training, I think what Helen mentioned earlier on, I agree with. What I'm looking at is a series of similar webinars to what Carl has delivered, perhaps focusing on areas around learning disabilities, but also in terms of using this group as a platform to say, what else do people need? Because I think this needs to be a citywide training offer. So, for example, what I did was, rather than keeping it internal to LYPFT, I made the training offer available to the city. So I think for us, let's work as a system. Let's kind of look at what other training that we need. But also, I think what Julie mentioned about reasonable adjustments, I think we all need to have some kind of training around what we mean by reasonable adjustments and some examples around reasonable adjustments. So we as a system are clear, and our patient service users and carers are clear as well when we talk about reasonable adjustments. And just to end on a note, we've got an implementation plan that goes through, like I said, the 5 steps. So as Sharon mentioned earlier on, I have to kind of ensure that I give the trust assurance that we are taking steps and measures to identify risks and also speak to people that are using our services, because for us that's very, very important to understand if there's any barriers and blockages. So thank you very much, and if there's any questions, by all means, I'll take those questions on board. Thank you.
Okay, thank you very much, Saeed. Doesn't look like anybody's got any questions there. The next item is from reporting back from the 3rd sector from Karen Fenton, but I don't think Karen's in the meeting. So is anybody else doing that, or maybe we've covered that really in terms of various different groups in the first part of the meeting?
Yeah, I think we probably cover in the first part of the meeting, Jonathan, and Karen hasn't actually sent the apology, but I'm not quite sure whether, anybody else would like to add anything else.
Okay, doesn't look like it. Okay, thanks. So next is Health Watch. I'm not sure is that you, Tatum, going to just feed back on what the next plans are for Health Watch?
We could do it, collectively with Hannah, if Hannah wants to add anything. But firstly, what I would like to share with the groups is, because this is the last meeting this year, and then we're going to leave the AIS focus for about 6 months. Actually, let me firstly spotlight Richard so that deaf people can see that properly. Sorry, no spotlight. Can they all see you properly, Richard? Okay, great. So what we are trying to do at Health Watch is about, because we always invite people to come to the call, and so that they can share the experience. And the next 6 months, what we're wanting to do is to collect this experience more widely, and so that, organizations, providers, commissioners will have a lot more evidence they can rely on and act upon, and that is the plan. And then when we're looking at how do we set out, these surveys and mechanism to collect the information, I actually found that it's difficult to lump all the services together in one survey, because if a deaf person wanting to comment on GP practice, which is very different to the hospital experience, for example, and then it's very difficult to pull out those information and to feed back to the organization accordingly. So the plan is we're going to set up individual survey links and individual mechanism for social care, for hospital, and for GP practice, and probably one for other health care services such as LYPFT and LCH. Now, whether that will work out or not, we're going to trial it with the Leeds Care Record. So at the moment, for example, I have set up a link to get feedback from GP practices, sorry, not from GP practice, for people to talk about experience at GP practices, and to run for 2 weeks to see whether people understand the information, be able to give the examples and evidence that we are looking for. So that is one plan. And so we're going to set up different links for, for different services. So that's one thing. Now, if that doesn't work, and then we can come back to the drawing board to see what might work better. And secondly, what I would like to ask the group is, when is the best time to launch this survey in a big scale? So Christina was talking about the plan can only complete it by January. So I'm thinking, in order to get the most up-to-date experience around accessible information standard, around when people accessing health and care, probably we need to launch it from February to April. So for 2 months, and then we give us a bit of some time to analyze the data, and then the data will be ready for the May meeting, which is the end of May. So that is my second question, the timing, And Caris from Leeds Society for Deaf and Blind has already said that we're going to set up a video link for these questions, once it's finalized, so that deaf people can actually contribute their experience or examples in a more accessible way. And obviously, Carl is looking for the accessibility for the blind people to see whether they can access the link and fill in the survey, in an accessible way. And then obviously, we can ask Julie and Wendy, to see whether that is okay for people with learning disability and autism. So that's kind of a bit of a plan that, we're forming at HealthWatch in terms of supporting this group to move the agenda forward. But the only way to make sure, or only way to see whether the progress has been translated to the front line, to whether those great progress has made a difference for people, we can only do so by listening to the people themselves. So, but that is kind of what we're trying to do. So in terms of the questions we ask, we'll be focusing on just 2 things. So say, for example, GP, has the GP asked you what's the best way to contact you? Secondly, the information you received from the GP, whether they were accessible. So say the GP has changed the way they deliver the service, during COVID. Has that been communicated? Has that been communicated to people in an accessible way? And thirdly is whether they have had a recent experience in accessing GP services, whether it's face-to-face or whether it's online, and what was that experience? And then hopefully, this can be replicated in hospital and in social care and other health services as well. So those are the questions that we're going to focus on. So the timing is that we need to get the lead from the group, whether February to April is any good, or whether we need to defer that a bit further in order to capture, the most recent experience. Okay, so that's kind of the plan. Yeah.
Okay, Hannah, did you want to come in at that point, or should we just check on the on what people think about the timing?
Oh yeah, if you want to check first. Yes, sorry, Jonathan.
Okay, so Tatum's suggesting that we try and run it from February to April. Does anybody not think that's a good idea? Okay, sounds like that is a good idea.
Okay.
Okay.
So do you think the links for different services would also work? So one for GP services, one for hospital, one for social care, and one for other healthcare.
Okay, what do people think about that? Does that seem reasonable? Again, I'll ask the same question. Does anybody think that's not a good idea? Okay.
I was just going to come in and say I think it's a good idea to have like them separate, but I know Leeds Care Partnerships are obviously working in individual parts of Leeds to look at winter planning, COVID, and that it could actually be integrated into that, because I know my next meeting for LS25, LS26 area is going to be the 3rd of December, and then we can sort of gauge what needs to be improved. And I know that third sector is looking at a lot of the improvements that way that they can do in the community and help the community through Christmas.
Okay, thank you. I think Hannah wants to come back on that point, Jane.
Yeah, I sort of agree with Jane, actually. I mean, I think there's two bits to the gathering people's experiences. I think it's really important to see how we've organisations, and as a city we've been able to progress with all the ambitions that we had before COVID. But I think there's something about capturing people's experiences now as well, and so we don't want to lose that, Tatum. So and as Jane said, the local care partnerships and each of the 18 local care partnerships, this is the sort of intelligence that would help them, and the work that Sharon's described as well with the accessible group at the CCG. So I think there's just something we just need to think about how we're hearing people's experiences now in terms of influencing the reset of services and what's happening now.
Okay, so we'll take that as another action, is to connect that work up with the local care partnerships and make sure that they're tied into it and informing it as well. Okay, that's great.
Can I just ask something? Sorry,
I didn't see who said that.
Wendy has got.
Sorry, it was me. I was trying to put my hand up, but there's so many of us on there. I just wondered if, because we've heard loads and loads about experiences during COVID and people passing on things that aren't working, and some of the difficulties there. Is there any scope within that to ask what people would want to see, what would help them? Are we getting that from this survey?
Yes, so the last question was about their suggestions on, what would work, well for them. But because this piece of work is around communication, about information, so it's around that kind of thing, but they can actually raise other points as well in the last question. So that is kind of, I can, in your agenda, there is a link to that survey, and everybody after the meeting, please have a look to see whether those questions will help us to capture what we want to know. So you can always email it back to me.
And sorry, just thinking about trying to ask people similar questions again, could we have anything in there about things that have already been implemented during COVID? Because there's such a lot being done,
yes,
based on people's feedback, and that this is the next stage, and what we will act on what people are saying. We'll collect that and then look at what's possible.
Yes, indeed, that's a very good idea. I think that's already been captured in people's achievement, which is, I think, Wendy, you didn't come to the meeting, the first part, we already talked about. There is some materials and which captures the providers and commissioners, what they have achieved so far, from listening to people's experience. But I think your point is really, really well made in terms of how do we then communicate this improvement on an ongoing basis back to people, because otherwise why would people give us their feedback? And so probably we can do that via our newsletter and via other mechanisms to constantly feedback to people, you know, you're not wasting your time to give us, you know, your experience and your opinion, and lots of people are acting on it.
Okay, thank you very much. Carys, I can see your hand up, and then we'll move to Hannah.
It was just to kind of link in with Wendy's point, really, because when Carl and Andrew and I had a discussion, one of the themes that we identified was that in a lot of cases where there's been examples that haven't been as good experiences, it's been because of the recording of information hasn't necessarily been there or hasn't been picked up. And generally, each of the examples that we discussed together was either because an interpreter hadn't been booked, or somebody had received a phone call, or somebody had received a letter that was inappropriate. What we did agree is that in situations where we've got examples of people that have raised an experience, straight away there was, you know, that whether it was the patient experience team or whoever it was responding to those situations and saying, right, what can we do to put this right? So I think it's a really important point, really. It's how you kind of get that across. And how we can maybe document that, because actually the feedback that's coming in is making a difference and it is being supported by the different departments. So it's just to kind of add that, really.
Okay, that's very helpful. Thanks, Carys. Hannah.
Sorry, couldn't come off mute. Just a quick, just reflecting on what we've talked about this morning. I think there might be some other bits of or roles that Healthwatch can take within this. Something around the information provision that's out there for people. We've heard in other bits of our work as well that people are confused around navigating services and what this new world out of COVID looks like. So I have talked with Dex, our communications person, before around us becoming maybe on our website having information about how to support people to understand how to access services. And I think, Wendy, I think you've done some work on this as well, so it'd be great to tie in with you at Advanet. But we could maybe do that around specific communities as well. We could say, you know, if you're someone with sight loss or someone with a learning disability. So that's just a piece of work that I think would be good to develop from a Healthwatch, and it'd be great to work with other partners if you're interested in that. We also do a piece of work called How Does It Feel for Me, which are real-time videos of people's experiences moving in and out of health and care services. And I'm just thinking that particular format, just thinking particularly around Jane's example, might be really useful. So we'll have a think about that as well. And we're also looking at doing some GP work we've spoken with the CCG around this, around supporting each practice in Leeds to understand around how, you know, is it easy to understand how to book an appointment on the website, you know, again, navigating that local GP practice. So again, we could, I think, bring some of that work into this and link it with yourself as well, Tatum, on the work you're describing there. And then there's also obviously our strategic influencing work around things like Leeds Care Record, but we might come on to that next. But I suppose just to give assurance that in all the places that we sit on, we will be advocating around the absolute importance around the accessible information standard. So just don't want you to think that for the next 6 months we won't be thinking about the accessible information standard, because we will.
Okay, that's great. Thank you, Hannah. And that's probably a very good point to move on to what this group is going to do next. So we will be back together looking at the accessible information standard in May, as I said earlier on. But there are other issues to do with access for all that we need to focus on. And we just need to have a bit of a discussion before we close at 12:30 about that. And Hannah, I think if you could set the context in terms of what the equalities priorities are for Leeds, and that will hopefully give us a bit of an angle on what we think we should be focusing on next.
Yeah, I mean, I suppose when we started this piece of work, when Sharon, myself and Tatum and others talked about this piece of work, we always had ambitions about it being wider than the accessible information standard, but we said because the issues were so large, we should start with the accessible information standard. But we, at the beginning, we talked about you know, are there barriers to accessing services because of literacy? Is it because English isn't your first language? Are there physical barriers to accessing health and care services? So our ambition was always to go wider. I suppose over the past year, I suppose just to say strategically, the inequalities has just risen up the agenda for lots of different reasons. But now, and I don't know if partners would agree from Christina and Helen and Sharon, but it isn't just us talking about inequalities anymore. Organisations and senior boards are starting to talk about inequalities, and that feels really positive. There is a citywide inequalities group which we sit on, and which people from everybody's organisations that are here sit on as well. And part of that is trying to understand, you know, what are the priorities around health inequalities, particularly around what can health and care do. And access is a key part of that. And the CCG have developed their first inequalities. Not that Sharon hasn't been working fastidiously around inequalities for a long time, but there is now a CCG inequalities framework or strategy. I'm not sure how we describe it, but access is one of the 3 priorities within that. So I suppose my reflections over the past year is that it has absolutely risen up the agenda. The other thing, I suppose some of the other things which we would want to influence, and we've talked about them already, is there's a lot of work around, well, it was the reset of services. People aren't resetting at the moment. It's back to sort of coping with COVID. But, you know, there's lots of work there that we would want to influence. And then I suppose the other issue that's come into focus since we started this work was digital inclusion, and the fact that such a lot of services now are being delivered in a different way, and what does that mean for inequalities? So that's just a sort of a roundup of, I suppose, how inequalities has risen up the agenda. Lots of people are saying that they don't want to see inequalities increase as a result of COVID, but as we've heard today, you know, the experiences that we've heard today, we are at danger of the barriers being increased by COVID if we're not careful. So, yeah, I mean, I don't know if you want me to express, Jonathan, what I think the priorities are. I think the way that these meetings have worked so well is because we've had people with lived experience coming to those meetings to talk about their experience. And that would seem like something that we would, and I think partners have found that really useful as well in terms of providing insight. So when we set out on this journey, I think the idea was that potentially we would ask people from refugee and asylum seekers organisations to come and talk about their experiences and the barriers that they're facing as people where English might not be the first language, or people from Gypsies and Travellers organisation, Leeds Gate, to partner with to ask them to come and talk about their experiences. So I'll leave it there, Jonathan. But that's just sort of some reflections and insight from sort of strategically where it is and where we thought we might be heading, or where we hope we might be heading actually, when we set out on this journey a year ago.
Okay, thanks, Hannah. So that's useful setting of the scene. Has anybody got any ideas about how you might want to focus our next bit of work in the context of that? What particular priorities there might be in terms of making sure that people, everybody is included effectively in the health and social care experience? Anybody got any ideas? Jane, was that your hand going up? I wasn't sure.
Sharon.
I've got my hand up.
Sorry, somebody's got their hand up?
Yeah, I've got my hand up, if that's okay. I don't want to interrupt anybody. Was Jane going to come in?
That's okay. Is that Wendy?
Yeah,
It
Wendy
is.
and then Sharon, I think. Sharon got her hand
I
up.
think it's hard for you to see people with their hands up. I suppose one of my worries is the thing that we hear a lot is people are supported to put forward their reasonable adjustments and access the services by people that understand their needs and know them well. So whether that's bid, whether it's a service that knows how to help that person to put forward their needs well. So what we see a lot is people being asked, what are your reasonable adjustments? And I totally agree with Julie, and people don't know what that means. And it's sometimes the staff aren't, or whoever's asking those questions aren't trained well enough to know how to ask them. But people often don't know. I think there's a massive need for self-advocacy resources, but ultimately a need for that support. So I suppose my worry, a bit depressingly, is we know there's massive cutbacks coming to all the frontline, those services, those third sector services who would normally be supporting people to do that. And that is my worry at this time, is that people often can't just answer a question like that very quickly without having some time to prepare and work on that beforehand. And in terms of videos, in terms of getting people with lived experience to speak on things, I worry sometimes about people just coming in very quickly to a session and whether it feels tokenistic. But I wonder if more of those videos like Hannah was talking about, where people have chance to prepare what they want to say, to record it in a small session that can be used on as an example at other forums, might be more useful, or might be one of the ways that we could do that. I know that some people with lived experience have said to me they feel a bit kind of rolled out, you know, coming to a service and suddenly being asked to kind of represent everybody. So my concern is the cutback on a direct support to help people put forward their communication needs in the first place. I know that's not a very easily resolvable thing, but I think it's something we should be considering.
Okay, thank you very much. Hannah, did you want to come back on that? I think.
Sorry, yes, I know Sharon had her hand up. Yeah. I mean, I think that's a really good point, Wendy, and we know local authority budgets are going to be massively impacted on, and absolutely agree in terms of the. So I think that's a really useful theme that I think we should progress and consider about what actions we could take around that. And I think just on the lived experience, and I don't know what others feel, Alison and Jane, but I know from the feedback that we've had from Mary and others, they found this experience really positive because we were co-producing those solutions together. So absolutely, Wendy, I think you're absolutely right about not asking people to come into an unfamiliar environment and just tell their story. Hopefully this whole process has been designed to be a sort of co-producing solutions together and not, a sort of, so completely take your point about that. I think there will be an increased call for I mean, what's really good is people are listening to us, that you need to have people with lived experience, but then people would say, well, how can I hear that? So I think it is good to think about the videos of people telling their stories if they're happy for their stories to be told.
Okay, thank you. Sharon, sorry, I didn't see your hand up before. Do you want to come in now?
Yeah, and I am going to have to go in a minute. I said to Tatum I would go in about 5 minutes ago and I'm still here.
I thought you'd already gone. That's
I can't leave. I've got to keep listening. So are we sort of exploring another focus for this group while recognising that work will continue ongoing in terms of the accessible information standard?
Yeah.
My suggestion would be, although it's difficult because everything's a priority in terms of that access and experience that people have, but I just wonder, like Hannah's sort of briefly mentioned as a suggestion, whether we look at refugee and asylum seekers, which would also bring in barriers that those communities experience in relation to first spoken language, but also because I do know that there are often challenges with registering, for example, at GP practices, particularly if people don't have an address or any identification, for example. I was involved in a task and finish group that were led by public health colleagues, but since COVID, the group hasn't met, that was looking at that very thing about challenges around GP registration, and it would be the same challenges for people that are homeless, for example. So just wonder whether we should maybe consider focusing on that, because in the same way that people accessing services that require BSL interpretation, sometimes the needs aren't always met. It is a known fact that people who require interpretation and translation services because their first spoken language isn't English, again, experiencing the same challenges. And it would be interesting to understand what the impact COVID-19 has had and the current situation that services are being delivered on those communities that need interpretation and translation services. Because I already know work that I've done in the past, is it with the Migrant Access Project that, and colleagues in Leeds City Council, quite often people that come into this country don't understand how the health service works. I don't, I work in it and I still don't get it. So, you know, with all the changes that we've all experienced, and it's had an impact on all of us in different ways, I think it might be certainly a couple of, you know, communities that warrant having a serious think about focusing next.
Okay, thank you for that. Christina, I can see your hand up too.
Thank you, Jonathan. I never know how easily it translates when we're trying to get attention on these big calls. I mean, I agree with everything that's been said so far. In sitting and hearing this conversation, one of the things that I reflect back on over the last months is the number of times I hear poverty being mentioned, actually. Not necessarily language access, but certainly poverty being mentioned a lot, and it's a topic that has come up in our internal reviews of people's experience. And if I'm honest, what I'm worried about is what we don't know about the people who are not attending our hospitals. I think we've got lots of information actually about experience for people who are coming into our services. We've heard some of that today, but there are mechanisms for us to capture that. The bit I'm worried about is those people who don't get as far as our doors actually, and the message that seems to be coming out is that quite a lot of that's related to poverty, and I actually don't understand what I can do about that, and that's what I would like to know.
Okay, I'm just wondering, because we need to try and wind this up now, and there's been some really helpful ideas there. I'm wondering about whether there might be two themes that we could move on that picks up people's discussions. The first one is that idea of reasonable adjustment, because that flows quite nicely on from the focus we've had around the accessible information standards, and it broadens it out and actually trying to get a better understanding of what that means from the perspective of people who use services and help them understand what a reasonable adjustment means. So that could be one area to work on. And the other area, which was something that was picked up in the digital inclusion project, was around the idea of precarious groups, which picks up what you were saying, Christina, about poverty, and about Sharon's point about refugees and asylum seekers, but also includes people who are homeless, people on the fringes of society. And maybe we could kind of have that as a focus as well for the next 6 months, about trying to engage people who are really on the edges and not getting into the services, and try and understand better about how we can create those pathways and help agencies to understand that better from their perspectives. I think it'll be quite challenging engaging with some of them, but there are some very active organisations about that we could link up with and maybe try and invite them along to the January meeting and start to expand that out. How does that feel to people about kind of picking up on those ideas and giving us those two areas to work on into the new year? I've seen some thumbs up to people. People are happy with that as a way forward. Yeah. Okay, that's good. That's good. I'm seeing some various comments. Okay, so I think probably what we'll do is we'll develop that. Tatum probably having some conversations with people in the meantime around tying up the AIS work for the next 6 months, starting to open up the areas that we've just talked about, and then probably the January meeting will be a different kind of meeting, and it'll be a more of a kind of forming type meeting and more open and working out the particular angles and themes that we want. So that meeting is scheduled for the 26th of January. So I just now want to wind up by thanking everybody absolutely enormously for the amount of work that you've put in today. I think from people with lived experience, you've taken risks, you've shared difficult situations, which has really helped the understanding. And from the agency's perspective, you know, you've engaged in this not in a defensive way, but in a way that really is about trying to make things better. And that doesn't always happen, I have to say. So that's really, really good that has happened. So I think it's been very positive. I think hopefully we've got a lot of energy to move forward. We'll focus on our AIS again in May, and hopefully we will have made some progress on the other areas that we've discussed between now and then. So thanks very much, everybody. If it's not, goodness knows what the holidays are going to be like, but let's hope we enjoy them in some way or others, and see you refreshed in January. I fear it'll be a Zoom meeting, but who knows, we might actually meet each other face to face at some point in the not too distant future. So thanks very much indeed, everybody. Tatum and Hannah, can we just hang on a bit? There was just something I wanted to have a word with you about, if that's okay. So thank you. Bye-bye.
Thank you, everybody.
Bye.
See you in the new year.
Yep.
Great. Great. Thank you, Jonathan. That was great.
I think that was a really